This is a hepatopancreaticobiliary scientific meeting held in 28th of October. My name is Mohamed Okba and I am a hepatopancreaticobiliary resident, and today I'm going to talk about anomalous pancreaticobiliary ducted junction, as known as pancreaticobiliary malfunction. Before we start talking about the anomalous pancreaticobiliary junction, we will need to know first what is the normal pancreaticobiliary junction. Normally, pancreaticobiliary junction was defined as the union of the common bile duct and the main pancreatic duct inside the duodenal wall, where the sphincter of Oddi surrounds them with muscular fascicles, which regulate the flow of bile and pancreatic juice. As shown in this slide, this is the common bile duct formed of four portions: the supraduodenal portion, the retroduodenal portion, the pancreatic portion, and the intraduodenal portion. The intraduodenal portion joins the main pancreatic duct to open. This union happens at the duodenal wall to open in the second part duodenum inside the ampulla of water, and this is guarded by the sphincter of Oddi. The anomalous pancreaticobiliary junction describes the abnormal junction of the pancreatic duct and the common bile duct that occurs outside the duodenal wall to form an abnormally long common channel. This happens more in females with a female to male ratio about 3:1, and this is more common in Asian population, especially in Japan. So, where is the problem? How can this abnormally long common channel cause any manifestation or causing the patient to complain? In patients with pancreaticobiliary malfunction, the sphincter of Oddi does not regulate the pancreaticobiliary junction, and reciprocal reflux between the pancreatic and bile juice can occur. Refluxed pancreatic juice injures the biliary epithelium and promotes cancer development on long term. As shown in this diagram here, this abnormally long common channel will lead to escaping of the common channel from the regulation by sphincter of Oddi. This will lead to reciprocal reflux between the pancreatic juice and the bile. This may lead to repeated attacks of pancreatitis, repeated attacks of cholangitis, cholelithiasis, and even on long term may lead to biliary cancer. Classification of the pancreaticobiliary malfunction: the Japanese study group classified anomalous pancreaticobiliary junction into four types. Type A, which is a stenotic type. The stenotic type is formed when dilatation of the common bile duct upstream of a stenotic segment of the distal common bile duct, which joins the common channel. This all will be shown in the next page. Type B, non-stenotic type. Non-stenotic distal common bile duct smoothly joins the common channel, no localized dilatation of the common channel. Type C is a dilated channel type. Narrow distal common bile duct joins dilated common channel, while Type B is a complex type, complex malfunction associated with annular pancreas, pancreatic divism, or other complicated duct system. This picture shows nicely the four types of the Japanese study group classification of the pancreaticobiliary malfunction. Type A, which is a stenotic type. Here we can see the distal CBD stricture preceded by a proximal dilatation, and Type B we can show that the CBD has no stricture or dilatation and it joins the main pancreatic duct away from the duodenal wall, while in Type C we can show an abnormally dilated common channel. In Type D we can appreciate the complexity of the junction between the CBD and the main pancreatic duct, and this type can be associated with, as an example, a pancreatic divism. We can even simplify this classification and put it into a more clinical way on the basis of the common bile duct dilatation. On the basis of bile duct dilatation associated with pancreaticobiliary malfunction, we can divide pancreaticobiliary malfunction into two types: those with dilatation and those without dilatation. Those with dilatation constitute 77%, and 50% of them diagnosed at childhood by right hypochondrial pain, repeated attacks of jaundice, and vomiting and fever. This can be easily confirmed by radiology. As an example, ultrasound will show cystic dilatation of the CBD, while on the other hand, pancreaticobiliary malfunction with no dilatation, the other 23%, less manifestation and less remarkable imaging findings, will lead to later diagnosis. They can be even diagnosed by the signs and symptoms of biliary cancer. Biliary cancer develops at an average age of 60 years in patients with pancreaticobiliary malfunction, which is 15 to 20 years earlier than in those without pancreaticobiliary malfunction. This slide shows how the normal pancreaticobiliary junction is shown in the MRCP normal film. Here is a CBD which joins the pancreatic duct at the duodenal wall, while this slide shows an abnormal pancreaticobiliary junction with dilatation. Here we can see an abnormally long common channel with this sinistrate is the main pancreatic duct, and there is dilatation of the common bile duct, huge dilatation as shown in this slide. This slide shows the pancreaticobiliary malfunction with abnormally long common channel. This is the no dilatation type. The pancreatic duct is seen here joining the CBD, and there is no dilatation whatsoever of the CBD. This case, how the pancreaticobiliary malfunction with no dilatation can has a very late manifestation, and this patient was a 49-year-old female, had no symptoms, and then she developed gallbladder cancer, which is shown here in ultrasound as thickening in the gallbladder wall. Same patient here. On the left is CT. We show a gallbladder wall thickening, and on the right is the MRCP for the same patient with abnormal junction between the main pancreatic duct and the CBD. Management of patient with pancreaticobiliary malfunction depends on risk-reducing surgery. For a patient with pancreaticobiliary malfunction with dilatation, Roux-en-Y hepaticojejunostomy is always done to remove all the dilated part, while in patient with pancreaticobiliary malfunction with no dilatation, risk-reducing cholecystectomy to remove the gallbladder, as it is the most common site for biliary malignancy in patients with pancreaticobiliary malfunction. Another example, this case was admitted in our department, hepatopancreaticobiliary department, Alexandria Main University Hospital. This is a 62-year-old hypertensive female, history of pancreatitis 2 months ago, admitted for routine laparoscopic cholecystectomy. Alkaline phosphatase on admission was 280, normally up to 114. Labs after 1 week, ALT was found to be more than 500, while AST was found to be more than 1000. Total bilirubin was 1.2, while alkaline phosphatase second round was more than 800. MRCP was done. ARCP was requested, while I will mention the results of MRCP on the next slide. While ARCP was requested, failed cannulation occurred, and then we will resort to another trial with ARCP 5 days after subsiding of the edema of the duodenal papilla. Here is the MRCP for this case. As we can see here, the CBD joins this very thin rim of the pancreatic duct away from the duodenal wall with an abnormally common channel, as seen in this picture very nicely. If we look closer, we can see another duct that joins the duodenum above the junction of the common channel. This is another pancreatic duct, and this patient has a pancreatic divism with a pancreaticobiliary malfunction. It is type 4 according to the Japanese study group classification. Pancreatic divism. Normally the pancreas develops in the fourth gestational week as a ventral bud and the dorsal bud. The ventral bud rotate and joins the dorsal bud to form the pancreas. Then the dorsal duct and the ventral duct joins together to form the main pancreatic duct, which joins the CBD and opens in the duodenum by the major papillae, which is guarded by the sphincter of Oddi. In cases with pancreatic divism, union between the ventral duct and the dorsal duct of Santorini fail to happen, this will lead to the pancreatic duct is drained by both the minor papilla, which drains most of the pancreas, the dorsal duct and the dorsal bud. While the ventral duct opens in the major papillae and drains only the unsnip process and a small part of the pancreatic head. Classification of pancreatic divism type 1, which is a classic type. Here there is no connection at all between the dorsal and the ventral pancreatic duct. This is the most common type, 70% of cases. While type 2, absent ventral duct, minor papillae drains all the pancreas through the dorsal pancreatic duct, while major papillae drains only the bile duct with no pancreatic enzymes. Type C, there is only filamentous connection between the dorsal and the ventral duct. This is constitute 5 to 6% of the cases. Management of patients with pancreatic divism can mostly be done conservatively, as the patient mostly is asymptomatic. Other manifesting patient can be treated non-operatively by pancreatic enzyme supplements. Patient may need minor papillotomy or minor papillotomy plus stenting, balloon dilatation of any associated stricture.